السلام عليكم ورحمة الله وبركاته. Today we will discuss hyperlipidemia. I am Dr. ايه البيلي, lecturer of diabetes and endocrinology. At the beginning, what is lipidemia? Or what is hyperlipidemia? It is the increased level of lipids or fats in the blood, including cholesterol and triglycerides. When we eat, a lipid is a component of our food. This lipid is digested and then absorbed. This absorbed lipid to move inside the blood and to move inside the circulation and to move inside our body, it must be in form of what we call lipoprotein. There are several types of lipoprotein. A lipoprotein is water-soluble spheres, consists of lipid core surrounded by a shell of soluble or water-soluble substance like الكوليسترول والأبوبروتين and الفوسفوليبيد. الأبوبروتين is a protein portion of a lipoprotein. According to the type of the apoprotein, there are different lipoproteins in our body. You know or you hear about some of them, like high density lipoprotein, low density lipoprotein, VLDL, which is very low lipodensity lipoprotein. These names. These names are the names of lipoproteins. The source of these lipoproteins are exogenous and endogenous. Exogenous, I mean the food, from the food. From the food, we get dietary triglycerides. These triglycerides form the chylomicron. The VLDL is an endogenous pathway. The VLDL is the triglyceride which is synthesized in our liver. The VLDL transports the hepatic synthesized triglyceride from the liver to adipose tissue and muscle. Hydrolysis of the VLDL, which occurs in the liver by what's called lipoprotein lipase enzyme, leading to decrease the triglyceride core in the VLDL, forming what's called intermediate density lipoprotein. Intermediate density lipoprotein become enriched in cholesterol ester. More cholesterol in the intermediate density lipoprotein will form low density lipoprotein. High density lipoprotein, its function is to transport the cholesterol from the peripheral tissue to the liver. Okay, low density lipoprotein transport the cholesterol from the liver to the peripheral tissue. The high density lipoprotein, the opposite of that, transport the cholesterol from the peripheral tissue to the liver. It is just an introduction of a lipid. It's a simple introduction to understand what is the disorder. I will explain after a while. Types of hyperlipidemia. There are primary hyperlipidemia. The cause is mostly genetic, or secondary hyperlipidemia due to other disease. Primary hyperlipidemia due to genetic mutation of various components of lipid metabolism, classified according to the type of the lipid. Disorder of LDL cholesterol alone, and there are only LDL hypercholesterolemia alone, or VLDL and the chylomicron hypertriglyceridemia alone, or combined. All types of lipids are high. Yep. LDL cholesterol alone, or VLDL chylomicron triglyceride alone, or combined hyperlipidemia. Familial hypercholesterolemia. It is one of the primary hypercholesterolemia. In the familial hypercholesterolemia, it is an autosomal dominant. Its cause is mutation in the LDL receptor, resulting in complete absence of a receptor protein, leading to decrease in a reduction of the clearance of LDL cholesterol. When we do lab or investigation for the patient, we will find increase in LDL with total cholesterol. Clinical presentation: tendinous xanthomatosis over the Achilles, patellar, and extensor tendon of the hand, arcus cornealis, xanthelasma around the eye. We said that it's autosomal dominant. It may be heterozygote or homozygote. If it is heterozygote, 50% risk of MI in the men by age 30. If it is homozygote, manifests cardiovascular disease, coronary artery disease, and other vascular disease early in the childhood and can be fatal. Primary hypertriglyceridemia. So, again, we can summarize primary hyperlipidemia. 1. Primary hypercholesterolemia, divided into familial hypercholesterolemia, polygenic and polygenic hypercholesterolemia. To differentiate between the both, familial hypercholesterolemia have tendon xanthoma وxanthelasma, while polygenic hypercholesterolemia no xanthelasma. Then, primary hypertriglyceridemia. The first, familial lipoprotein lipase deficiency. Lipoprotein lipase, it is the protein I said before, or it is the enzyme that digests a very low density lipoprotein and change it to intermediate density lipoprotein. It's an autosomal recessive deficiency of a lipoprotein lipase or its cofactor, so that no destruction to the lipid. So when we investigate our patient, we will find increased chylomicron, increased triglyceride, moderate increase in VLDL. It's presented by hepatosplenomegaly, splenic infarction, anemia, granulocytopenia, thrombocytopenia, pancreatitis, lipemia retinalis, eruptive xanthomas. Clinical presentation: we can find premature coronary artery disease, syndrome of obesity, hypertriglyceridemia, hyperinsulinemia, and hyperuricemia, metabolic syndrome in early adulthood. Combined hyperlipidemia. Primary hyperlipidemia or primary hyperlipidemia are divided into primary hypercholesterolemia, primary hypertriglyceridemia, so the last one is combined hyperlipidemia. Combined hyperlipidemia like familial combined hyperlipidemia. Also it's autosomal dominant due to overpopulation or overproduction of VLDL as a result of excess hepatic synthesis of apolipoprotein B, which form VLDL. When we investigate the patient, we will find increase all in lipids, the total cholesterol, LDL cholesterol, with triglyceride, and VLDL. Presented also by xanthelasma around the eye, coronary artery disease, and other vascular disease. This beta lipoprotein, it is due to abnormal apolipoprotein E. The apolipoprotein E, it is the protein portion through its VLDL known its receptor over the liver and dehydrolyzed structure. Abnormality in this lipoprotein E with no destruction of the VLDL. Lab the same as a familial combined hyperlipidemia, while clinical presentation is coronary artery disease and peripheral arterial disease. This is the cutaneous manifestation we said before. The photo show what is the mean of tuberous xanthomata, xanthelasma around the eye, tribal marrows in the hand, eruptive xanthoma with tendon xanthomata over the tendon. Secondary hyperlipidemia, which is due to systemic disorder or drug. What are the systemic disorders? Like hypothyroidism, like diabetes mellitus, especially when poorly controlled, obesity, renal impairment, nephrotic syndrome, hepatic dysfunction, or drugs like oral contraception in susceptible individuals, thiazide diuretics, and corticosteroids. How to investigate? Most patients are asymptomatic and have no clinical signs. Screening of a high-risk individual such as family history of coronary heart disease, family history of lipid disorder. If we found patient with xanthoma or xanthelasma, obesity, diabetes, hypertension, acute pancreatitis, patient will undergo renal replacement therapy. Measurement of the plasma lipid should be done after 12 or 14-hour fasting. Now there are some era to not to fast, but fasting is better when we will measure triglyceride, total cholesterol normal value below 200, triglyceride normal value below 150, the high density lipoprotein to be 40 up to 60, LDL to be below 130, or we can calculate it by this equation. Total cholesterol subtract the sum of the high density with triglyceride divided by 5. How to treat hyperlipidemia? The beginning, diet. To reduce the total fat intake, I mean reduce the dietary fat. Then substitution to monounsaturated and polyunsaturated fat. How? The monounsaturated oil like olive oil. Polyunsaturated oil such as sunflower with safflower with soya oil should be used. The mixed oil is bad, not healthy. Reduce dietary cholesterol intake. Liver should be avoided. Also, eggs are rich in cholesterol. Their total contribution to the body's cholesterol pool is small, and they can still be part of balanced lipid-lowering diet. Increase the intake of fiber. We decrease the alcohol consumption. We try to achieve ideal body weight. Drugs. There are several drugs in the market, like almost common is statin, simvastatin or atorvastatin. They are competitive inhibitor of hydroxymethylglutaryl-CoA reductase, which inhibit a rate-limiting step in cholesterol biosynthesis. What is the meaning of rate-limiting step? It is the step responsible for overproduction and increasement in the cholesterol biosynthesis. This drug contraindicated in pregnancy, lactation, and acute liver failure. Side effect of it is elevation of a liver enzyme, diarrhea, myositis. Statin can reduce the LDL by 30 to 50%. Only 10 to 20% reduction in triglyceride. Tiny effect on HDL. The other group is the cholesterol absorption inhibitor. From its name, It inhibits the gut absorption of the cholesterol from food and bile, like ezetimibe. It's very effective when be given with the statin. Reduce the LDL by additional 10 to 15%, 10% reduction in the triglycerides, 5% increase in the HDL. Contraindicated during lactation. Side effect diarrhea, abdominal discomfort. Bile acid sequester, like cholestyramine and colchicine, they bind the bile acid in the gut, preventing the enterohepatic circulation. Liver makes more bile acid from cholesterol, depleting the cholesterol pool. Side effects: gastrointestinal mainly, constipation, bloating, irritability is a problem. Fibric acid derivatives like fenofibrate limit substrate availability for hepatic triglyceride synthesis, promote the action of lipoprotein lipase which destructs the lipid, contraindicated severe hepatic renal impairment, gallbladder disease, pregnancy. Side effects: mild elevated liver enzyme, reversible myositis, nausea, gallstone formation. Nicotinic acid derivatives inhibit the lipid synthesis in liver by reducing the free fatty acid concentration through inhibition of lipolysis in the fat tissue. Contraindicated in pregnancy or lactation. Nicotine leading to headache, flushing, nausea, malaise, itching, elevated liver enzyme, glucose intolerance, hyperuricemia, activation of peptic ulcer. All of these side effects make it limited value. Omega 3 reduce the hepatic VLDL secretion. Side effect: occasional nausea. عافانا الله وإياكم. Thank you.